Hello and welcome to your 1403 AHS lecture on outcome measures. By the end of this workshop you should be able to describe what an outcome measure is and its purpose, understand the reliability and validity of an outcome measure and what a minimal detectable change and minimal clinically important difference means in the clinical setting. So what is an outcome measure and why do we use them? So it's a clinical measurement used to detect change over time. So an objective measurement, such as time, that we measure in seconds for an outcome measure such as the timed up and go test, or a subjective measure such as using questionnaires as the quality of life questionnaire. So why do we use them? Well, they're used to help us identify a problem which might benefit from our intervention. So, for example, we might look at muscle strength or gait speed and how physio can impact on these problems. We might use it to identify change in performance over time, looking at the benefits of our intervention. So we could use the same measure repeatedly at different points in time to see how progress is occurring. So for example, it might be gait speed. We can use outcome measures to evaluate the cost effectiveness of interventions. So by comparing two different management programs, we could use the same outcome measure to detect change due to two different types of interventions, for example. So we need to have a purpose in why we're measuring, and we need to then use the most appropriate measure to detect change in what we're trying to change. So we want to be able to identify a problem, we want to be able to use this information to assist us in planning an intervention. We want to use it to evaluate our interventions and also then helping us to document and effectively communicate what we're finding as a result of these outcome measures. We can use outcome measures to establish a database for what is normal or what is normal for a disease-specific case, such as Parkinson's disease. We can also use outcome measures for research and evidence-based gathering. But remember, it's almost as bad to measure for the sake of measuring than not to measure at all. So doing a whole lot of measurements doesn't necessarily help us decide what we need to treat. So when we're thinking about the purpose of our measurements, so what am I actually trying to change? So by asking this question, it's helping us to identify what type of measure we're going to use and when we're going to use it. So for example, if we're trying to reduce the number of falls that a patient is having, we need to measure the number of falls in the first instance. So we might use something like a falls diary. Then we need to also measure something that might be associated with the reason for them falling, such as a balance measure. So we'll talk about these in your tutorials and practical classes, but the modified clinical test for the sensory interaction imbalance, or CTSIB, or a functional gait assessment, the FGA. We might also want to have a look at somebody's ability for sitting balance. So for example, we could use the functional independence measure, which is an overall measure of global function of a person, or we could look more specifically at a sitting balance measure. So how long can somebody sit unsupported in those early stages of rehab? So if we're looking at somebody's gait as another example, so we could also use the functional independent measure, or FIM outcome measures, to give them a score of their ambulation or gait using the FIM descriptors. So what we use in that is how many people do they need assistance from? Is it one or two or maximum assist, or are they independent? And what kind of aids are they using in order to be walking? However, we also might want to quantify somebody's ability to walk. So we can use something like the timed 10-metre walk measurement. So we could use this to measure our gait speed, and so we could then quantify how fast they're walking and use that as a documentation for looking at change over time. So what features should our outcome measures have? First of all, they should be easy to administer and not take too long. So we don't want to be spending all of our time doing outcome measures with our patients before we even get a chance to start treating them. Our outcome measures should not cause any pain or any discomfort to the patient. And we should be able to have some normal values to be able to compare our patient's performance to what might be normal for their age and height or their specific pathology. So you were introduced to some of these principles in last trimester in 1402. So thinking about, is an outcome measure reliable? So can it be repeated on different occasions and by different people? Is it valid? So does it measure what it's actually intended to measure? And is it sensitive to change? So will it detect changes in performance over time? So if we think a little bit more, look a little bit more closely at reliability. So is the measure consistent and free from error? Is there a standardised procedure or protocol that's being used? So do we have standardised equipment? Do we have standardised environmental setup? Is the assessor trained to perform that outcome measure? And are we using standardised instructions? So if we think about the intra-rater reliability, this is referring to the degree to which the score obtained from one trained observer agrees with the scores obtained when the same observer applies the measure at a different time. The inter-rater reliability refers to the stability of a measurement between two or more trained observers in rating the one performance. So let's say we had the student and the clinical supervisor both measuring the same performance by one patient and coming up with the same result. And finally, our retest reliability. So the stability of the measurement over two or more measurement occasions. So if we keep using that, are we still getting the same reliability over time? Then if we consider our validity, so is it measuring what it is intended to measure? So concurrent validity is the test is compared to a gold standard or other external measure at the same time frame, or predictive validity, where the test is compared to a gold standard or other external measure at a set time to predict future outcome. So when are we going to use outcome measures? Well, different measures may be required at different stages of management or rehabilitation due to their sensitivity of change. So are we wanting to document improvement or deterioration in activity, structure or function? So for example, if our patient is unable to walk without assistance, then we're not able to use the Timed 10-metre walk test, but we can assign an objective measure of walking using a different outcome measure. And this might be the mobility and locomotion scores of the global measure of the functional independence measure, which is the FIM. So once then the patient is able to walk without assistance, then a sensitive measure like the Timed 10-metre walk test can show change over time. So the fact that they can't do it at an initial stage of rehabilitation is also an outcome in itself. So we could say that they were unable to do it at this point in time because they were still requiring one-person assistance to walk, but 2 weeks later they were then independent with walking, so we could then get our baseline measure for a Timed 10-metre walk test. So the other things we need to consider when using an outcome measure are floor effects. So when the measure is too hard for the patient to complete, then we're not able, the response of the test is that they're at the more negative end of the scale and there's no room to detect any deterioration. So if they can't do it, we can't use that test. So an example might be a standing balance test where we ask the patients to stand with their eyes open and feet together. If the patient's unable to stand unsupported, then we can't do this test, so we can't detect any change in their ability to balance in standing. On the flip side, here we can talk about the ceiling effects of an outcome measure. So when the measure is now too easy for the patient to complete, the response of the test is at the more positive end of the scale, and so maximum scores are achieved early and we're unable to detect any improvements. So an example of this again with our standing balance tests, if we're standing with our feet together on a piece of foam with our eyes closed, and the patient is able to do this successfully for 30 seconds, then we're not actually going to see any further improvements being detected using this test because they've reached the highest end of this test. The next things we need to consider when using outcome measures is the minimal detectable change. So this is described as being able to identify real change in performance and not just error in the measurement process. So an example might be the timed up and go test, which is the time taken to stand from a chair, walk 3 meters, turn around and walk back to sit down on the chair again. So a paper by Huang et al. In 2011 reported a minimal detectable change in the timed up and go test in Parkinson's disease patients is 3.5 seconds or 29.8% change. That would be if, for example, if they were taking 17 seconds to perform the timed up and go test, unless they dropped that score by 3.5 seconds, so coming down to 13.5 seconds, then we're not actually measuring a minimal detectable change in performance. Then the next thing to consider is the minimal clinically important difference. So this is more of a patient-centred concept. So it's the smallest improvement considered worthwhile by a patient, and the standard for determining effectiveness of a given treatment and describing patient satisfaction in reference to that treatment. So a change in the performance and in a score might be important or significant to the clinician, but the patient may not perceive this as being important to them. So if we're thinking about our outcome measures, we can put them into different categories of what we're actually measuring. So the majority of physiotherapy measurements that we use will be assessing aspects of patient function across all domains of the ICF. So we can look at body functions and structures, so things like impairment measures such as joint range of motion, muscle strength, pain, ataxia and bradykinesia. Or we can look at the activity level, such as balance in sitting or standing, falls and falls measures, so the ABC scale or the activity specific balance confidence scale or a falls diary could be used for measuring falls. For measuring mobility and gait, we could use measures such as the timed up and go, the timed 10-metre walk test or the 6-minute walk test. Or we could look at upper limb function, so looking at measurements such as the 9-hole peg test or the action research arm test. Our global measures of function, so looking at, again, all of the domains of the ICF, might be our motor assessment scale, or MAS, or the functional independence measure, or FIM. These measurements quite often might cross across different disciplines. So the FIM is used by allied health and nursing staff to assess a patient's global functioning. So other categories of outcome measurements might be looking at participation. So again, some multidimensional measures. So we might, as an example here, look at the quality of life questionnaires, such as the AQOL or the SF36, or the dizziness handicap inventory. So this is looking at how somebody's specific condition is impacting on their day-to-day quality of life. Or we could look at a disease and pathology specific outcome measurement. So these examples might be the stroke impact scale or the UDPRS, which is the United Parkinson's Disease Rating Scale, or a spinal cord independence measure, the SCIM. Now, when we're wanting to apply our outcome measures in the clinical setting, we need to consider these concepts of reliability and standardisation of a test procedure. We need to make sure we have the right equipment, we're giving the correct instructions, so again, using standardised instructions. Our environment is appropriate, so have we made our environment free from clutter? We've got the correct height chair for that particular standardised test, or we've measured out our distance appropriately for a test such as the timed 10-metre walk. And then is the assessor trained to perform that particular outcome measure? So the other things we need to consider is the outcome measure suited to that client or patient? So is it is there any specific disease associated with that outcome measure that only people with that condition the outcome measure is used for? Or do we need to just consider the simple fact is, can they perform this test? And does it suit their abilities? And the other things to think about is, do we have some normal values to make comparisons to? Because if we're just getting a set of numbers or a set measurement, how are we then going to interpret the results of these measures? And that's where having normal values to compare to is really important. So we can use outcome measure manuals we don't expect everybody to remember every outcome measure under the sun, but the Australian Physiotherapy Association National Neurology Group has published a selection of commonly used outcome measures for neurological rehabilitation. They're actually now up to the 4th edition of this manual, and it's available to purchase from the APA website, and they do offer student discounts for this as well. So in the upcoming weeks, you'll have access to a document on your Learning at Griffith site, which is going to outline the outcome measures that we're going to be looking at during your tutorials and during your practical classes. So we'll just make these ones available for you for now, and as you move through the years in your program, you will then be learning different outcome measures and have access to their standardised protocols as well. Thank you very much. We will see you for outcome measures in your tutorials and practical classes in the coming weeks.